Urinary retention at its most basic is defined as an inability to micturate or pass water. However, as we shall see, this is not a necessary condition for this diagnosis to be made. We can basically talk about two distinct types of urinary retention. These are acute urinary retention and chronic urinary retention. However, as always in medicine, there are very few absolutes, and it is important to also be aware of acute on chronic retention, where the acute picture develops on a background of chronic features. So, acute urinary retention is characterized by sudden inability to urinate in the presence of a painful bladder. Chronic urinary retention, on the other hand, is defined by the presence of an enlarged but painless bladder, either with or without difficulty in micturiation. When talking about the causes of any of these, and in fact causes of anything in medicine, it is useful to have the three most common causes memorized. For this case, in men obviously, these are benign prostatic hypertrophy, malignant prostate disease, and urethral strictures. However, for a more comprehensive list, you should try and break things down a bit. Personally, I like to divide the causes into general and local, and then go from there. The local causes are all the problems that result in an actual physical obstruction to the flow of urine. Just like when you consider the causes of dysphagia or, say, bowel obstruction, the causes can be broken down into luminal, wall-based, or extraluminal. Problems within the lumen of the urethra could be clots, say in clot retention, which is a very common complication of any cause of bleeding within the bladder, or with the passage of a large impacted stone, or urinary calculi. Problems within the wall could be strictures, say secondary to chronic infection, or rarely urethral tumours. Finally, important pathologies outside the wall include prostate enlargement, which may be either benign or malignant, severe constipation that results in physical pressure on the proximal urethra, or rarely other pelvic masses such as uterine fibroids or large ovarian pathologies. In terms of the general causes, the most important one to be aware of is surgery itself, as it is very common for patients in the post-operative period, particularly those who are predisposed to retention, to develop this early after any procedure. Important contributing factors here include the use of anaesthetic drugs, pain, and disturbance of pelvic nerves in surgery itself. Other important general factors include neurological disease involving the bladder. In fact, it has been shown that more than half of patients with a history of stroke will experience some degree of urinary retention. Other important examples would include multiple sclerosis and acutely cauda equina syndrome. Interestingly, the pattern of presentation follows the location of the lesion. If, say, in multiple sclerosis, the upper motor neurone tracts are mainly affected, this leads to chronic retention with reflex incontinence. But if, on the other hand, the lower motor neurone tracts are affected, chronic retention results, but with mainly overflow incontinence. Finally, any drug with anticholinergic properties can also contribute to urinary retention. Important examples include the anticholinergics themselves, as well as drugs with important anticholinergic side effects, such as antihistamines and some antipsychotics. Sympathomimetic drugs, such as over-the-counter oral decongestants, can also contribute to urinary retention by increasing alpha-adrenergic tone in the prostate and bladder neck. So let's now move on to talk about the presentation and management of the different types of urinary retention. First of all, acute urinary retention. This is a common problem that you will see a lot on the wards as a junior doctor. In fact, it is estimated that up to 30% of patients over the age of 80 will develop at least one episode of acute urinary retention during their lifetime. Acute retention is characterized by the sudden onset of inability to pass urine, often with lower abdominal pain. On examination, you should expect to find a tender suprapubic area and a suprapubic mass that may extend up to the umbilicus. This mass is also dull to percussion. The bladder may be palpated when it holds more than 200 ml of urine and will be dull to percussion if it holds more than 150 mils. A PR exam is important to assess the size and shape of the prostate, to look for severe constipation, and also to test perineal sensation. This is important as loss of perineal sensation could indicate cauda equina syndrome. The PR exam, however, is best left until after the retention has been relieved with a catheter. Obviously, it is important to do investigations. Do consider, however, that these should probably be done after you have catheterized the patient, as urinary retention is very painful, and it would certainly not be kind to leave your patient in retention until the lab had processed your prostate-specific antigen. So, how do you sort out a patient in urinary retention? Most simply, this involves prescribing analgesia and inserting a Foley catheter. This should be performed using aseptic technique to avoid the introduction of infection. Some doctors like to give a shot of gentamicin to cover the procedure. Catheterization is something that you should try and get used to performing as a student, so try if possible to get someone to talk you through it. In men with acute urinary retention from benign prostatic hypertrophy, there is also evidence that starting pharmacological treatment with alpha blockers at the time of catheterization improves the probability of success when attempting to void without the catheter. In this population of patients, long-term treatment with 5-alpha reductase inhibitors such as finasteride can also reduce the risk of further episodes of retention. If catheterization is unsuccessful, this means that there will be a tight stricture within the urethra. Management options then include dilatation of the stricture under local anaesthetic or general anaesthetic. Alternatively, on occasions, a catheter may be inserted directly through the abdominal wall into the bladder. This is known as a suprapubic catheter. Many patients will have an obvious cause for going into urinary retention, such as urinary tract infection or surgery, possibly on a background of known prostate disease. However, if not, they should be investigated thoroughly. As always, you should have a rational approach to investigations. I like to use the standard table of investigative modalities that include cultures, bloods, imaging, scopic techniques, and finally functional or special tests. Remember that you should be able to justify why you would wish to do each test. In this case, you would wish for your cultures to do a simple urine dipstick and culture, as urinary tract infection can be both a consequence and precipitant of urinary retention. You may also wish to consider urine cytology if a tumour was suspected clinically. In terms of bloods, urine electrolytes would be useful to assess renal function. A PSA or prostate-specific antigen is important, as it may be elevated in the presence of prostate cancer and benign prostatic hypertrophy. Remember, however, that PSA has no place in the acute setting in diagnosing the cause of retention. Important imaging can include a plain radiograph of the kidneys, ureters and bladder, looking for renal or bladder calculi. An ultrasound may also be useful to assess bladder size, examine residual volume, and look for the presence of hydronephrosis. Further investigation might include visualizing the urethra and bladder with cystoscopy and performing urodynamic studies to further quantify bladder function. So let's move on now to talk about chronic urinary retention. This may be of two types, high pressure and low pressure. In high pressure urinary retention, there is, as the name correctly describes, a build-up of pressure within the bladder because of some obstruction to outflow. This back pressure can build up to such an extent that there is disruption of the vesico-ureteric junction and back pressure through the ureters and kidneys. This can eventually result in renal failure. In low pressure retention, however, the primary problem is with the bladder wall that has become atonic. This does not therefore result in back pressure through the ureters and to the kidneys. As already mentioned, presentation is different as chronic retention has a more insidious onset and is not associated with pain. There may, however, be overflowing continence as the sphincters of the bladder tend to fail with bladder distension. On examination, there will often be a non-tender and non-tense suprapubic mass that is dull to percussion. If patients in chronic urinary retention are in pain, have a UTI, or significant renal impairment, it is important to catheterize them to relieve hydronephrosis and to allow their renal function to normalize. Obviously, it is important to investigate the cause of their urinary retention, and useful investigations have already been fairly well described. Many patients with chronic urinary retention, particularly in association with neurogenic bladder, choose to self-catheterize when needed, and this has been associated with increased patient satisfaction and decreased urinary tract infections. So, in this podcast, we've talked about the two types of urinary retention. Try and remember the most common causes of retention and break down the problem anatomically in order to formulate a more complete list. While we've talked about many of the investigations that can be done, remember that acute urinary retention is very distressing to the patient and can be rapidly relieved with catheterization of the bladder. We've also talked a little bit about chronic urinary retention, importantly its differences both in presentation and sequelae compared to acute urinary retention.